Research Grant Recipient webinar series, hosted by the Pi Theta Epsilon Omicron chapter at Boston University. Today, Ashley Stoffel and Mansha and Mirza will be presenting on the behalf of Dr. Sandy Magaña about their work on promoting home and community participation among Latino children with ASD. The presentation will be 20 minutes, and then there will be 10 minutes for questions at the end. Please type any questions you may have in the box on the right of your screen throughout the presentation. Now I will turn it over to the co-investigators, Ashley and Mansha.
We want to begin by thanking you for inviting us to discuss our intervention research on promoting home and community participation among Latino children with ASD. We wanted to begin by giving you some background information related to our intervention grant. So to begin with, we know that Latinos are the largest racial ethnic minority in the US. And we also know that Latino children represent one of the fastest growing populations to be diagnosed with autism spectrum disorders in the country. However, Latino families face several challenges related to getting diagnosed, accessing treatment options, and using community-based resources. And many of these challenges are listed on our slide here. They include limited English proficiency, low parent education and income, limited access to key networks, and these challenges typically tend to be exacerbated for children from immigrant households. And when we're talking about Latino children, this is an important consideration because more than 63% live in households where either one or both parents are first-generation immigrants. So really there is a need for culturally sensitive family empowerment interventions targeted at this group. And with this need in mind, we developed an interdisciplinary intervention that was focused on improving home and community participation for preschool children from Latino immigrant families. And we wanted to target this age group because we felt like this is the age group that tends to fall through the cracks a lot. These children have aged out of early intervention services and might not be in school yet, or even if they are in school, they're new in that setting, and parents are not always aware of how to advocate for therapy services to be available through the school system. And so we developed an interdisciplinary intervention that combined evidence-based OT strategies like environmental adaptations to address a child's sensory needs, sensory modulation strategies, and we combine these with the concept of family empowerment from the field of social work. The intervention was also informed by the thrust toward family-centered and culturally adapted care within pediatric OT services. And finally, the most innovative aspect of our intervention was that it built upon the community health worker or the promotora de salud model. The community health worker model is actually becoming increasingly popular with helping with management of chronic health conditions in the adult population. And community health workers or promotoras are typically members of the target community that share the same social, economic, and cultural characteristics. And being trusted members of the community, they are uniquely positioned to implement culturally appropriate services and can play many roles such as patient advocate, educator, mentor, outreach worker, and translator. And they are also, again, best placed to bridge the gap between the healthcare system and diverse and underserved populations. We felt like the community health worker model especially holds promise for Latino immigrant families because research shows that new immigrant families tend to be isolated and are often in need of stronger formal and informal social supports. In our case, the promotoras or community health workers were themselves parents of children with ASD, and that was a critical piece of the intervention because we know that parents especially want to hear from other parents who have shared the same experience of raising a child with ASD. So with that background, I'm going to now hand it over to Ashley, who will give you a few more details on the intervention.
All right. So this slide shows our intervention, and I'm going to kind of describe what we did. We targeted Latino immigrant parents of preschool children with autism spectrum disorder, and as Mansha described, we really wanted to target this preschool age, given that often there's a gap in services at that time. So the intervention involved 8 weekly 1-hour sessions, and these were conducted in the family's homes. And this was another key piece of our intervention design, was really meeting the families where they are in that natural environment of their home, and that is not necessarily typical of preschool age services for OT. So the intervention began on that first session with a comprehensive assessment of the child's participation, and this was using the preschool activity card sort. And so this also helped to help the OT and the promotora to discuss with the family about 3 participation-based goals, and these were directly identified from the preschool activity card sort assessment. Other assessments that were done in that first session was a structured assessment of the child sensory profile and the home environment. And so all of this information from the assessments was utilized to develop an individualized family-centered plan for each child and family. So that was done in the first session. And then sessions 2 through 7 were really focused on achieving that plan. So looking at those 3 participation goals, using a variety of strategies, and these included things like parent coaching, low-cost environmental adaptations, and the majority of those ended up being things like changing the setup of the existing environment, or task modification, such as providing a space for the child to calm, or thinking about meal times and setting up the same chair or the same space for the child, turning off the TV during mealtime, some of those environmental adaptations. And this was versus introducing new items into the environment. And so we had budgeted for things like maybe ordering some sensory supports that we really found out these families didn't need, that those low-cost environmental adaptations were successful in meeting the goals. So the first 3 sessions were co-led by the OT and the promotora, and then sessions 4 through 7 were led by the promotora only, and with phone consultation from the OT. And so that was for the group that had OT and promotora. And then the final session, the OT came back again and co-led that with the promotora. Another piece of our intervention was we did have intervention manuals, and we developed one for the occupational therapist and for the promotoras in the study. And these were translated into Spanish because the promotoras primarily spoke Spanish as their primary language. We also did an 8-hour training for the promotoras, and this was led by 2 bilingual pediatric occupational therapists. So these are our study objectives, and we conducted pilot testing and feasibility evaluation of the intervention, which was our objective number 1. And then objective 2 was to look more at comparing these preliminary outcomes of looking at families who receive just the OT only services versus families who receive the OT plus promotora. So our study design was a 2-group randomized trial, and we recruited 10 families who were randomized into 2 groups. So one group of 5 families received professionally delivered OT only intervention, while the other group, the intervention was collaboratively delivered by an OT and the community health worker, or the OT plus promotora. So to address aim 1, so that feasibility and acceptance of our intervention, we collected process measures throughout the intervention, and these were pertaining to recruitment and retention of both the participants and the promotoras. Also whether the randomization procedure worked or not, and we also assessed fidelity of the intervention, so whether the intervention was delivered in a way that adhered to the intervention protocol. So we also collected outcome measures, and we will focus on those in a moment, but I'm going to start with the process measures. So our process-related findings. So 3 promotoras were recruited into the study, and as Mansha mentioned earlier, all 3 were caregivers of children with autism spectrum disorder, and it happened that those children were slightly older than the preschool age. And really, we didn't even have to go out and recruit these promotoras. So our PI, Sandy Magaña, had an ongoing study where she was also training promotoras on a different intervention, and she had a waiting list of individuals that could not be recruited into that study, and so we were able to use those promotoras in our study. So all 3 of those promotoras completed the training and then continued to be retained throughout the study. We were also able to recruit all 10 of the families. We did find that recruitment was slow and happened over 5 months for a number of reasons. For example, we only use passive recruitment strategies. For example, we had a community organization distribute flyers, and then we waited for families to contact us. And so something that we recognize thinking about going forward, we will need to use more active recruitment strategies, such as partnering with parent groups or other community organizations. We also had some geographical limitations. So we had a couple of families who lived more in the Chicago suburbs, and they were interested in the study, but they couldn't be enrolled because none of the 3 promotores could travel that far out to the suburbs. So, and then also at the same time as we were recruiting for our study, there were also other studies in the area who were recruiting Latino families with children with autism. So the recruitment pool was getting a little crowded. None of the families reported any problems with the randomization process, but the promotores did. Because of the study design, they had to wait until a family was randomized to the OT plus promotora group. And it just happened that the first few families were randomized to the OT only group. And so there was, they felt that there was a time lag between the training and then actually getting to deliver the intervention. So in the future, we should consider a different randomization procedure, such as block randomization or providing a booster training for the promotores. In terms of fidelity, the OT and promotores had to complete detailed case notes for each session that they completed with the child and family. And we had a fidelity checklist that 2 of the PIs who had co-developed the intervention independently filled out against the case notes, and it was agreed at greater than 95% agreement between these 2 reviewers that the intervention was adherent to the protocol. So for AIM 2, we collected outcomes, data at baseline, immediately post, and then 3 months post the intervention. Our main outcome measures were the preschool activity card sort, the SCQ, and the family outcomes survey. And this is a measure of families' understanding of the child's strengths and needs, as well as advocating for their child, helping their child develop and learn, having support systems, and being able to access the community. This slide shows some of our participant characteristics. Some of the highlights are that we did in our families, we did tend to have lower income, all related their spoken English as poor or fair. And you see some of the other characteristics there. We did tend to have more boys than girls, and these all fell within that preschool age range of 3 to 6 years. These were some of the key goals that were identified. So if you remember from the preschool activity card sort in that first session, 3 participation goals were identified for each child. The categories in the left column are based on the preschool activity card sort, which divides different areas, the responses into 7 different areas. And so you see that self-care was the primary goal for a lot of the children and families, followed by education, which includes things like waiting in line, sitting in a chair, being able to participate in an education type setting. We also had goals in the area of community mobility, so being able to go to the library or to museums or use public transportation. Social interaction, so waiting for a turn or being able to talk to another child, those kind of things. And then low demand leisure, and so being able to play by oneself was another goal that we saw. Okay, and Mansha is going to share about some of our results.
So I'm going to begin with our outcome comparisons that we did between the 2 groups, and starting with the preschool activity card sort. I'll tell you a little bit about this measure. It asks the parent to rate whether or not their child is participating in a variety of activities in several categories, including self-care, education, community mobility, domestic, social interaction, low demand and high demand leisure, like Ashley just mentioned. And the measure yields 3 scores: a score for importance of specific participation goals, a score for extent of the child's participation in those goals, and a score for the parent's satisfaction with the child's participation. We mentioned previously that each family identified 3 participation goals for their child, and we here are presenting the findings from the 2 measures of the extent of the child's participation in those identified goals and the parents' reported satisfaction with the child's participation. We found that at baseline, there were no significant differences between the 2 groups on both extent and satisfaction with participation. We also found that over time, from baseline to follow-up, which was conducted right after the intervention, both groups showed a significant improvement in both extent of the child's participation in selected goals and the parents' reported satisfaction with the child's participation. Moving on to the social communication questionnaire, this is an assessment of the child's communication and social interaction skills. And on this assessment, we want to see a decline in scores over time because lower scores indicate that the child is communicating and interacting more or communicating and interacting better. We found that on this measure at baseline, children in the OT plus promotora group demonstrated lower levels of impairment. However, the differences between the two groups at baseline were not statistically significant. At follow-up, both groups showed improvement. So there was a trend in the right direction. Scores were lower over time for both groups, which showed that the child was improving on these skills. However, change from baseline to follow-up was not statistically significant for either group on this measure. And finally, the family outcome survey. This is an assessment of families and parents' self-reported understanding of their child's needs, whether they feel confident in helping their child learn and grow, whether they feel confident in advocating for their child's rights, and whether they feel confident in accessing community resources. The assessment yields a total score and 5 subscale scores, and I will talk about the subscale scores in the next slide. But on this slide, what you're seeing is a comparison between the two groups on the family outcome survey total scores. And interestingly, and quite unexpectedly, we found that family scores on the outcome survey decreased over time from baseline to follow-up for both groups, the OT group and the OT plus promotora group. Unlike the social communication questionnaire, on this assessment, we actually want to see an increase in scores over time. And so that was a finding that we did not quite expect, and we decided that we needed to dig into the subscale scores to figure out what was happening. So what you see on this slide are subscale scores in the areas of understanding the child's strength, knowing your rights, helping your child develop and learn, having support systems, and accessing the community. And on each of these subscale scores, we found that families in the OT plus promotora group were reporting an improvement over time, except for the final one, accessing the community, whereas families in the OT only group were showing a decline over time. And we will discuss the implications of this finding in our final slide. But before we go there, I also wanted to share with you findings from focus groups that we conducted with parents in both groups, OT and OT plus promotora. Our qualitative data from these focus groups complemented our quantitative findings. Overall, parents were really satisfied with the intervention. We have a quote up there from a parent saying that the occupational therapist gave me a lot of strategies for my child. We also noted that families appreciated having the occupational therapist as an emotional support. And here's a quote from a parent who was in the OT only group. And she said, the OT was a lot of help. With her, I would let everything go. There was moral support of her listening. I felt like I would vent. She cared and knew well. She understood what I was going through. And we also have a quote from a parent in the OT plus promotora group. And this parent is speaking to the importance of having another more experienced parent involved in their child's care who they can commiserate with. And she says, always with other parents, one starts to talk about our children. And I see my child is not the only one. So then one feels like, oh, this is not happening only to me. And so what are some of our take-home lessons from our study findings? Well, we found that our study design was feasible and it can be implemented in a larger trial. We found that our experimental intervention was acceptable to families. Initially, we were concerned that families would not really be opening up their homes to us, but we realized that families actually appreciated having the intervention in the child's natural environment, and they did not have to be concerned about getting the child into a car, getting the siblings into a car, figuring out parking to get down to our OT department. And so just getting the intervention in a time and place of their convenience was beneficial. We also found that it was feasible to train promotoras in co-delivering the intervention with an occupational therapist. We feel like based on these findings from our pilot study, we have proof of concept which means that our data indicate the intervention is promising. We found that families and children in both groups show similar trend regardless of whether they were receiving the same intervention from an occupational therapist only or whether they were getting it from an OT plus promotora. We found that the involvement of promotoras, especially ones who themselves have experience of raising a child with ASD, might be important to improve family empowerment outcomes, and that we especially need to boost the element of our intervention that focuses on educating families about community resources and helping them better access these resources. And finally, we want to acknowledge that this was a small pilot study and that our findings should be confirmed through a larger trial. And concluding with our references and an acknowledgement to our funder and our research assistants, as well as the promotoras and the families who participated in our research. Thank you, and we can open it up for questions at this time.
Thank you. We'll now begin the question portion. The first question comes from Maria Lopez, and she is wondering if the program would be generalized in the future to other ages or diagnoses.
That's a great question and something that we have thought about, and that is the plan. Is now that we have been able to show promise with this initial intervention, is to look at other populations, even other ages within children with autism. So that's definitely something that we would like to continue to think about.
As well as other cultural and language groups.
Thank you. So the next question comes from Kara, and she was wondering if the OTs were the same in both the control and the non-control group, and if the OTs in the control group had any previous experience with working with Spanish-speaking families.
Yes, so there was only one occupational therapist for both groups, and she herself was a bilingual OT and Latina, and so that was definitely something we also heard in the focus groups with the families. Is that was a positive, was her previous experience. She had several years of pediatric experience as an OT and particularly working with Latino children and families. And so that's another piece that we've looked at for the future, is what this could look like if it was a monolingual OT working with bilingual promotoras.
Thank you. And so the next question is, for OTs who don't have access to promotoras, what can they do to be more effective when working with Spanish-speaking families?
That's a big question. Yeah, that's a great question. You know, I think some of the things, particularly from our study, were just being culturally responsive from the beginning in terms of looking at our assessments. We looked at which assessments had been translated and validated and adapted within, you know, into Spanish, and then validated with the Latino population. It was one thing that we definitely considered in terms of looking at our assessments and outcome measures.
Also, using the facts was, again, really beneficial in making sure that the goals that the OT and the promotora were working on were identified by the family. So even for OTs that do not have access to promotoras, that's another key take-home message, is helping families identify goals that are important for them and their children, and then individualizing the treatment plan according to those goals. The other thing is, I was just presenting this information at another conference over the weekend, and there were no OTs in the audience, but there were speech therapists, and they work alongside OTs. And a couple came up to me later and said that this was so critical because typically, you know, clinicians don't have access to promotoras. And typically, clinicians are monolingual. You know, our clinician was really like a gold mine, you know, several years of experience, culturally identified as being a Latina, bilingual, and everything. And so in the absence of that, you know, your next best option really is to make sure that you're working with a competent language interpreter to make sure that you have accurate and open communication with the families you're working with. That would be our suggestions.
Thank you. Our next question is from Michelle. what was included in the training that promotores received?
Yeah, so we developed a manual, and then they had the 8-hour training, and some of those components included beginning information about autism. Although all of these promotores had a child with autism, we wanted some consistency in that understanding of autism spectrum disorder. We trained them on just our intervention delivery process, and then also there was a whole section on just what is occupational therapy. We also, it was a very interactive training, and so we wanted to hear from the promotores because they are moms, or in this case, we're moms of children with autism, what their experiences were previously with OT, what their thoughts around OT were, so that again we could try to insert some fidelity around that in terms of bringing in their stories, but also making sure that they were going out to meet these children and families with a good understanding of what OT is, what a participation goal looks like. We used a couple of case examples in the training to talk through what the intervention piece could look like. There was also information about how to consult with the occupational therapist, because that was a big piece that for those OT plus promotora families, that those sessions 4 through 7, where the promotor was the direct interventionist, there was still that contact with the occupational therapist through phone calls, checking in, those kind of things. So there was some training around that piece, as well as just how to write those detailed case notes, and things that should be included, and how best to help us achieve that fidelity with our intervention.
We also included training videos. So there was one video of the clinician administering the facts to a parent, just so they get an understanding of what we mean by participation in home and community activities. And then we had a couple of training videos providing examples of OT intervention. So for example, there was one video of the clinician and the parent working to create visual cues that were put up in the child's bathroom to help the child through the process of undressing, taking a shower, brushing his teeth. And those we thought were really accessible to the parents because they could see the intervention in action.
We have a question from Kara, and she asked, what are your long-term goals for this project?
Well, so I can tell you what our intermediate goals are. So at this point, we have submitted an application for a bigger grant to be able to implement this with more families, because what we have based on this research is just proof of concept preliminarily. And in order for this intervention to really be evidence-based, we need to implement it with more numbers of families and have a more real-world element to the intervention. Like we mentioned, our clinician was bilingual, bicultural, and that's not the reality of pediatric OTs out there. So in the next iteration of the study, we want to see whether promotores are able to collaborate similarly with a monolingual OT. And then really moving forward, we want to also try and figure out if this really is a cost-effective and feasible intervention, because it might just make OT services more financially accessible for families that are not able to afford therapy services outside of the school system. And so we hope to do that again with our bigger study, and then disseminate the intervention in a way that clinicians can implement it, perhaps on a sliding scale, for families to be able to access services they otherwise would not really have access to.
Thank you. We're going to wrap up the questions. And I want to thank Ashley and Mansha for presenting both theirs and Dr. Magaña's research with us today.
Thank you.
Thank you.
Our pleasure.
Okay, now we're going to switch it over to Dr. Susan Magasi.
Hello.
Hi.
Hi. Okay, so I need to shut down your slides and reopen mine. Okay, sorry, just give me a second here. Okay, there. Okay.
Hello, so I would like to welcome anyone who is just joining us for the AOTF Intervention Research Grant Recipient Webinar Series, hosted by the Pi Theta Epsilon Omicron Chapter at Boston University. Dr. Magasi will be sharing her work titled Healthcare Survival Skills, Development and Partial Implementation of a Peer Provider-Led Intervention. The presentation will be 20 minutes, and then there will be 10 minutes for questions at the end. Please type any questions you may have in the box on the right of your screen throughout the presentation. Now I will turn it over to Dr. Magasi.
Hi, thank you. Well, I'm happy to be here, and I'm also a little humbled to be following Ashley and Mansha's elegant work. But I think you will see in this presentation that there are some similarities in terms of approach, but also some differences in terms of scope and focus. So that is just our introductory slide. We have recently changed the name of our intervention to Healthcare Survival Skills. It was originally called Navigating the Healthcare System as a Person with a Disability. And oddly enough, that was not grabbing the attention of a lot of participants. And even our institutional review board recommended that we come up with a catchier name. So it was actually at a conference talking about healthcare disparities among people with disabilities that somebody raised the issue of basic healthcare survival skills that people with disabilities really need to have in order to be successful in getting their healthcare needs met in our complicated healthcare delivery system, complicated and fragmented. So as you probably know, the AOTF released research priorities in 2015, and among those, issues surrounding healthcare access for people with disabilities were among them, which was a nice synergy for us because I have been focusing on issues of healthcare justice for people with disabilities for about the past decade. So just to give a quick overview of what we're hoping to do today, I would like to describe the process that we used to collaboratively create our intervention. Our project is a community-based participatory project that involves both foundational research done in partnership with the disability community, and then all of our intervention work was designed and is in the process of being implemented in collaboration with our partners in the disability community. And then I'll also spend a little bit of time talking about the strategies that support our intervention, really with the aim of helping build the capacity of people with disabilities to get their healthcare needs met. So that includes the ability to access healthcare, the ability to receive quality, responsive, patient-centered care, and then also, ideally, long-term, achieving the outcomes that they need and deserve. So we'll start with a little bit of background, talk a little bit about some limitations in our current rehab practices, our development process, and some preliminary findings. But we'll talk more about some of the challenges that we've actually experienced in accruing our sample, some of the reasons why, and maybe if we have a little bit of time at the end, you can give us some suggestions about moving forward. So just by way of background, and I'm sure these few facts are not unfamiliar to you, people with disabilities have been called an unrecognized health disparities population. So although initiatives like Healthy People 2020 have identified people with disabilities as a population at risk for health disparities, they're largely excluded from a lot of health disparities research and health disparities interventions. But as you can see, they're high-cost users of healthcare services, And they are also a group who just experience tremendous barriers to healthcare access, quality, and outcomes. So we have been working on this work, and when I say we, it really is a partnership between us as academic researchers with an interest in occupational therapy and disability studies and disability rights, and members of the disability community. So we have been working collaboratively on issues around healthcare access for a number of years. And through that, we've started to develop a conceptual model, which you can see up there on the screen, of healthcare access for people with disabilities. This is based on significant qualitative input from people with disabilities. We've conducted focus groups with several hundred people with disabilities, really trying to understand the issues that they face in trying to access healthcare. It was based off of a model of healthcare access barriers for people in racial and ethnic minority groups. And in that instance, it really just emphasized the barriers. So what we've been trying to do is elaborate the model both to be more inclusive of some of the unique barriers that people with disabilities face, but also recognizing that there is tremendous strength and knowledge within the disability community, and that by mobilizing and marshaling those strengths, we can hopefully help tip the balance. We really do emphasize in this model some of the modifiable barriers to care, things related to accessibility. You know, are the clinic environments physically accessible to people with disabilities? Do they have equipment that can move up and down so people can transfer onto a table, for example? What are some of the informational barriers? So this ties in both to knowledge barriers within people with disabilities themselves, of understanding how the healthcare system works and understanding their own health needs, but also the knowledge of healthcare providers in terms of recognizing the unique needs of people with disabilities and being responsive to those and knowing how to address them. We heard about tremendous attitudinal barriers to care, people feeling disrespected, people feeling discriminated against within the healthcare system. Structural barriers just have to do with the organization of care, that some of that fragmentation, and then also some of the financial barriers to care. We work primarily with people with lower socioeconomic status, and a lot of people who get their healthcare funding through Medicaid, which here in the state of Illinois is in crisis. But through those focus groups, we also heard a lot about the supports. Dealing with the healthcare system led to some strong senses of advocacy and patient activation, excuse me. There was also informational support, so a lot of informal information sharing within the disability community, emotional support, similar to what Mansha and Ashley spoke about in their presentation, of recognizing that I'm not the only one that's going through these kinds of experiences, and it's not that I just had a particularly bad experience or bad healthcare encounter. And then instrumental supports are sort of more of that physical, tangible, hands-on support. So by tipping the balances between barriers and supports, it has an impact on people's access to healthcare services in the first place. Can you get in? Can you get there? Can you get an appointment? And also on the quality of the interaction with the provider. So what is that patient-provider interaction like? Are their needs being met? Is the care responsive? Which ultimately all have an impact on health outcomes. And we've defined out some of the key health outcomes that we are interested in: global health status, development of secondary conditions. You can also use this model to look at things like high cost utilization, and then also participation outcomes, because that's always one of the ultimate goals of rehabilitation and disability services. So what's nice about this model is that it does provide an entry point for intervention, that you can tackle either ways to break down barriers to care or ways to build capacity and knowledge through some of those supportive interventions. It's a relatively flexible model that you can apply it to different groups no matter what the diagnostic categories are or some of the other factors that come into play. So this model really does serve as the foundation, foundation for a lot of the work that we do related to healthcare access for people with disabilities. We believe as part of our work that healthcare and access to health is really foundational to all other areas. You know, it's difficult to engage in occupations of interest or to participate in meaningful community roles, work, self-care, leisure, without a certain baseline of health. We also hear through our qualitative work that sometimes negotiating these different healthcare systems can become a full-time job for people, leaving limited opportunities for people to engage in other activities that are important to them. But in spite of how critical healthcare access issues are to people's participation and survival, really, ability to stay in their homes and to participate meaningfully, it is not an area that is typically addressed as part of rehab. So this leaves people to kind of figure things out on their own. We also recognize that people with disabilities have rich experiential knowledge on how to navigate the healthcare system. So some of those supports that we identified in the earlier slide, but that knowledge is not systematically or routinely shared with people. So what we hear is that people are encountering the same barriers over and over, and every individual is sort of forced to figure it out on their own. But you know, we as occupational therapists have professional knowledge in environmental evaluation, in goal setting, in action planning, and that by implementing or applying some OT processes to the occupation of negotiating the healthcare system can really be a way to help promote access to care. So those are some of the foundational issues that came into our desire to do this work and to create this intervention. So we're calling it healthcare survival skills. It's an OT disability peer-led intervention with an educational focus. It uses a provider peer-led model. So first of all, peer support is a hallmark of the independent living movement, and there is growing evidence for the use of peer educators in a variety of contexts. And it really builds upon this knowledge and lived experience. Having been there, done that, I can help you find your way through some of these challenges. Occupational therapists, as you know, have skills in a lot of important information, activity analysis, self-advocacy strategies, pathways to accommodations. Sometimes we don't always make those strategies transparent to people. Certainly there's more of a movement now through programs like the co-op model that really teaches people not just the skills but also the process for working through challenges. So what our study seeks to do is to pair the strengths of the disability community, experiential knowledge, with those strengths of the occupational therapy community, with our professional knowledge. So, oh goodness. So based on that, we developed this educational intervention to help people develop the skills and knowledge to become more effective managers of their own healthcare. It was developed collaboratively with researchers, occupational therapists, and self-advocates for disabilities. Thinking of that larger model, we decided that for a short-term initial intervention, it would be important to hone in on just a smaller number of barriers, and thought for people with newly acquired disabilities, and this was done in a lot of consultation with our community partners, that the physical, attitudinal, and informational barriers were the most important to tackle. It emphasizes the process of barrier identification, identifying client needs, and then goal setting and action planning. It's divided up into 5 modules, and we're still in the process of learning how best to spread out those modules. So our target population experiences a lot of challenges with transportation. So we wanted to make sure that we provided an intervention that was practical for them to come and do, while also not overloading them with too much information all at once. So we're trying to determine the best organization of those 5 sessions. And we're targeting people who self-identify as people with physical disabilities. In the final slide, we'll talk about some of the challenges that we faced in terms of recruitment and some of the things that we've had to do to reorganize that. So these are our 5 sessions, and we thought a lot about what was the best way to organize the content. And we decided to do it sort of sequentially, as you would go through the process of deciding that you need to go to the doctor in the first place, making that appointment, being in the appointment, and then reflecting on the appointment. So I just wanted to give you a little highlight of each of our 5 sessions. So session 1 introduces people to that healthcare access barrier model, but in a very simplified, stripped down version of it. So here we really use the process of having people identify some of the issues that they know that they're experiencing relating to these different kinds of barriers. Session 2 is really about planning for that appointment, and this is about knowing your rights and being able to advocate for them proactively at the time of setting up the appointment. So thinking through what are the things that I need as a person with a disability to have that healthcare appointment. So this is based a lot on ADA kinds of principles and also the types of accommodations that people might need. Session 3 is really an appointment planner. We hear a lot from people that they get in to see that doctor, and probably this happens to many of us as well, and they feel rushed and they feel like they can't really talk about everything that's important to them. So this is just a planning worksheet to help them stay on track and make sure that they get their needs and questions met. And it really allows them to sort of drive the ship. You know, in healthcare, sometimes things go well and sometimes things don't, and it's important to do that reflection back on what worked and what didn't work. So we developed a self-reflection questionnaire that people can do after to really think about, okay, how did my provider communicate with me? Was I happy with it or not? Did they show me the respect that I want and deserve? And or my access needs met? We think it's important for the RED to recognize what they did well and also some things that maybe they want to work on in the future. And then in the final session, it really is a wrap-up, but we also want to empower people to do a little visioning about what their healthcare provider should be like and what are those characteristics or traits that they really want to see in a healthcare provider, and then to do some decision making. You know, I might decide that, yeah, it would be great to have a provider that really understands disability, but this doctor's office is around the corner and I can get in for an appointment when I need to. So doing that careful weighing of balances and checks that they do throughout. So each session has an educational component, and then where they are presented with the content by the team in tandem, so by the OT and the person with the disability who's their co-facilitator. We also have a case study that we embed through all. So we follow Thomas throughout each of these phases in the process. And those worksheets that I showed to you, first they learn the concepts, then they go through the case study of analyzing a lower stakes case for them by looking at what Thomas's experiences are, and then we ask them apply it to their own situation. So it's really a process of, again, making transparent that OT process, learning some of the content, and following it through. So as you can see, I spent the bulk of my time talking to you about our intervention and what our plans are. And that's because we've faced some pretty significant implementation challenges throughout the course of our study. We've struggled a lot with accruing the sample. We find when we talk to physicians and when we talk to OTs, they think it's a great idea. They think it's something that their clients and patients could benefit from, but there's something that's happening between, yes, it's a great idea, and actually getting those referrals in the door for the project. So we are actually in what's called a no-cost extension for our project. So we've been given a little bit of extra time to try to get our numbers up. Some of the reasons, and it's similar to some of the things that Ashley and Mansha mentioned in their presentation, our referral process is pretty indirect. We reach out to clinicians and then ask the clinicians to introduce the study to their clients, who then, if they're interested, call us. As you can imagine, there are many links in the chain where that process might break down, especially given how busy clinicians are, and also how overwhelmed many people are when they first acquire a disability. Managing your own healthcare might not be your highest priority right after you've had a stroke or a traumatic brain injury. So both patients, clients, and therapists have expressed some concerns about patient readiness. When are they ready to tackle these kinds of issues? And it might not be in that first year post-onset as we had originally planned. The reason we wanted to tackle people in that first year was to have a more consistent baseline for comparison. But we know that these needs persist long-term, so we're thinking about how we might adapt it to target people who've had been living with their disabilities longer term and have maybe had an opportunity to interact more with the healthcare system and experience some of these challenges. People are busy. And after you've had a disability, they are busy doing their rehab, they're busy trying to get their life back together, they are busy managing their healthcare, and this might feel like just one more thing layered on there. So we've heard in our discussions with the disability community through some of our focus group work that they are just, if there's something that they can put off doing and that takes a lower priority, sometimes they are wanting to do that. I already mentioned the issues around the time commitment. How do we organize those 5 sessions? How do we make sure that each one is value adding? And then we've also noticed, both from our original focus groups, what really identified those issues of health literacy, where people really don't know what they don't know. And if you've only experienced substandard care or bad quality care, you might not recognize that there's something better, or that you have different rights within the healthcare system. So those are some of the issues that we're trying to negotiate and figure out. These are just our collaborators and acknowledging the partners. One thing we also wanted to make sure that it's all well and good to help build people's capacity to advocate for healthcare services. But if those barriers are still there, and if you don't tackle the barriers on the provider side, then you're still going to be running into brick walls. So Sherry Muir at St. Louis University is one of our collaborators, and she and her students have developed some companion materials for the provider side issues. And that's really all I have to talk to you about today, but I would love to hear your thoughts, questions, suggestions on how we can move this work forward.
Thank you. So now we'll begin with the questions. And the first question is from Maria, and she's wondering if the worksheets have public access and what your plan was for generalizing the program so that individuals can eventually navigate the healthcare system on their own.
Yeah, that's a great question. Not currently, because we haven't had a chance to fully test them yet, and we think some refinements will likely be warranted. We have had some conversations about potentially putting some of this content in ways that consumers could access directly. So whether it's looking at sort of mHealth kinds of applications of it, other ways of getting content to consumers more directly. Right now, we really like the approach of having those as facilitated groups with the OT and the disability peer, because we think that adds a certain richness to it. But more widespread scaling up and dissemination. We would also, our real vision is to see this as a tool that occupational therapists could actually use as part of clinical practice. It's only 5 sessions and could likely be fewer than 5 sessions. So is there a way that this can become a reimbursable intervention? Maybe not in inpatient because people are so swamped with everything they already have to do there, but maybe in a rehab context or outpatient kind of setting. Or like some of the chronic disease self-management courses that are offered as adjuncts to standard therapy.
Thank you. So our next question is, what's the screening process or recruitment process for peer educators?
Oh, that's excellent. So as part of the manualized intervention, we do spend some time delineating out what would make a good collaborator. We provide some recommendations to occupational therapy practitioners who would be interested in developing this kind of intervention of how they could find a partner to work with. What are some of the collaborative skills that they would want to have, and how should they work together? For our intervention, our interventionist peer was also part of our developer, but some suggestions around many facilities now have peer mentoring projects as part of an inpatient rehabilitation or collaborating with centers for independent living. And then also just some traits and characteristics that you would look for in a co-facilitator. And obviously, even though it's manualized, you can't just crack open the book and deliver it cold. So we talk about the preparatory phase 2 of how the two groups or the two partners can work together.
Thank you. So we're going to wrap up the questions. And I just want to thank Dr. Magasi for presenting her research with us today, and to everyone for attending. Have a great day.
Thank you.